I can, Mark can.
I can.
I can hear you fine.
Okay. All right, are we good to get started? All right. Good morning, everybody. We're going to start our FY 2027 budget hearing for Panhandle Health District. Today's date is June 16th, 2026. The time is 11:01 a.m. I'm going to call this meeting to order, and we will begin with the Pledge of Allegiance. And Eric, can I get you to lead us off, please?
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. And I would like to go ahead and do a roll call by county. We'll start with Boundary. Present. Bonner.
Here?
Present. Shoshone.
Here.
Benoit. Present. And Kootenai County is present. Okay, public comment. Does anyone wish to speak? Hearing nothing. We will move on to our welcome remarks, and we'll lead it off with Dr. Thomas Fletcher.
Well, good morning. Commissioner Matari, we spoke following the last budget meeting, and you had requested that Panhandle Health generate some different budgetary options to sort of run through the numbers and find out what the consequences would be if one flavor of budget were adopted versus another. And so the two leading options considered were A, the COLA, the 2% COLA, and the other option, B, was with clinic and without clinic. So I'm just going to summarize what the fiscal ramifications would be if we either included or excluded COLA and clinic. And you can see that summarized on that one page, options 1 through 4. So if we keep the clinic and eliminate the COLA, all right, there are a couple of different ways to think about that. Eliminating the COLA will, of course, liberate something in the neighborhood of $180,000. Now, we could take those funds and I guess give them back to the county, or we could take those funds and use them to pay for the clinic in lieu of the unrestricted funds. We had received some feedback from different commissioners that there was apprehension about dipping into unrestricted funds to support the clinic in this ramp-up period, because we were needing to hire more personnel to, in fact, run a full flush clinic. So removing the COLA will liberate, obviously, some funds. How you want us to deal with those funds is, of course, your decision. The next option would be to eliminate the clinic but keep the COLA. All right. So it turns out that if you eliminate the clinic, you will liberate roughly $78,000. Now, when I first saw these numbers that Christine had generated for us, I'm thinking to myself, how do you go from a clinic where the budgetary request is $2.1 million, and yet if we kill it, you only save $78,000. That struck me as counterintuitive. I didn't understand that. But Christine was patient enough to explain how that is. All right. So you are creating two conditions that converge if you kill the clinic. The first condition is that the clinic, you understand, generates a fair amount of revenue all on its own. It sees patients and you bill for those clinical events. So if you kill the clinic, you have you have neutered the generating capacity of that enterprise. And the second condition is that there are overhead expenses, there are administrative expenses that are shared by all departments of Panhandle Health. And the clinic is sharing, it is suborning its fair share of those administrative costs. But if you kill the clinic, you have not eliminated the other administrative costs. So therefore, those costs have to be redistributed to all the other departments. So when you work the numbers, as Christine has done, and I believe she's competent, it ends up that when you kill the clinic, you only save $78,000. And then if you want to work that out as a pro rata share of a given county, say you are Benoit County or whatever, you're at about 4% of that. So you can do the arithmetic and figure out how much of a savings that's going to be to Benoit County. At this juncture, by the way, let me, at your pleasure, by the way, if I'm on a roll, how much time do you want me to have?
As much as you need to make the case for what you want to do.
Okay, so I want to underscore if you will, services that the clinic program writ large performs for the 5 counties that go above and beyond a discrete clinical event. So in other words, you think of a clinic as where sick patient comes in, they see a nurse or a doctor, some interchange occurs, you generate a code, it makes money, the patient goes away happy because they have a prescription or they have a path towards health and happiness. But there are a lot of other things that the clinic enterprise does that are not reflected in the actual seeing of a patient. And here's a list of them. We answer the phone to provide all sorts of information to people. So people want to know about birth certificates. How do you get them? How do you not get them? We give them that information. Elderly support, housing support, lice removal, I don't know, referrals for dental services, counseling studies of one kind or another, recreating historical immunization records, fertility testing, the list goes on. There are innumerable services, community resource services that Panhandle Health renders that don't generate an income, don't generate a CPT code, but nevertheless, someone's answering the phone and someone is rendering a service to the community. You kill the clinic, all these services go away. So be mindful of, unintended consequences. If you go to the last option, which is no budget and no COLA, then the counties would see a return of, I don't know, $150,000 or some amount of money. So I can have one final comment. Commissioner Matari, we discussed this, and that has to do with the potential role that the Panhandle Health Clinic could serve for the counties moving forward. And this is a role that is above and beyond a role that has been performed heretofore. It has to do with providing health services for the county employees. Now, to be quite honest with you, I didn't even know this was an option until Commissioner Korn called me up about, 3 months or so ago and asked me to attend a special meeting at the county office in Bonner County. And on that morning, there was a firm, PMR Healthcare, who was making a presentation to Bonner County commissioners, as well as the city of Sandpoint and the city of Ponderay. And I think Lighthouse had their HR department there, and there were some other, what's the name of that? Kinitsu. Well, there's a software firm that's on 3rd Street and Church. But it's not Kinitsu. It's something like that, though. but they employ many hundreds of people. So in other words, what you have are businesses that employ a number of people, and then you have governmental organizations that employ a number of people. And if you pool all those employees together, then this outfit, PMR, would come in and provide managed healthcare services to all of the participating organizations. Now, this is not free. This is for a sum of money. And they make money. And I'm not privy to the specifics of their business model. Commissioner Matari is far more familiar. But what he specifically asked me is, would Panhandle Health be in a position to provide managed healthcare options for county employees? And the answer is, I believe we could. And you say, well, how can you suffer from so much hubris, Dr. Fletcher? You haven't. What have you done in your life to say that you could provide a sophisticated healthcare product? Well, that's a legitimate question. And I do suffer from some measure of hubris to think that I could do what these guys do. However, when you look into what they do, they provide nothing more than standard cartel establishment medicine. It's the same program. They're not doing anything. There's no magic to their program. So how do they make money? How do they manage? Well, they secure a discount on drugs. They have their own formulary. So they buy drugs at bulk, and so they get a discount. So they save money there. Well, they also can provide screening services like mammograms and colonoscopy and blood tests and other sort of diagnostics where if you buy in bulk, well, you get a discount. That's their business model. Now, I would submit to you that that business model is designed to make money. So consider the following. You say, well, we have a formulary and we can prescribe drugs cheaper. What if you practice medicine where you don't prescribe as many drugs? You ever heard of the pharmaceutical escalation trap, where you prescribe a drug and that ends up having consequences that require then the addition of another drug and a third drug? You know, 75% of us are chronically sick. And if you want to look at, there are 6 billion prescriptions a year written for Americans. That's 19 prescriptions per American per year. And these numbers are escalating. And you say, oh, but Dr. Fletcher, what makes you so sure that we don't need those 6 billion prescriptions? Well, let's just pick on one. I could pick on any number. Let's pick on reflux disease, GERD. Okay, so you have some heartburn. You go into your doctor and you say, I have some heartburn. Or still, I just have chest pain. Oh, well, you need, an acid reflux drug, a proton pump inhibitor, a PPR. Well, what does a PPR do for you? Well, it certainly neutralizes the production of hydrochloric acid in the stomach. But what are the unintended consequences of that? Well, you end up having a malabsorption syndrome. I'll just give you one example of that. You now malabsorb magnesium. Well, you say, well, what do you need magnesium for? Well, before you know it, you have some cognitive disturbances, you have some muscle disturbances, you have downstream effects of this alteration in the way your gut behaves, the physiology of your gut. So now, before you know it, you need mood-altering drugs, you need fibromyalgia drugs, you need drugs that either jack you up or take you down, you need supplements because you now have disturbed your metabolic capacity to maintain an appropriate pH. So now you're leaching bone you're leaching calcium hydroxyapatite from your bone. Now you need to go on bisphosphonates because you're developing, osteopenia. You might think that what's coming out of my mouth is total gibberish, but please understand, those 19 million prescriptions are the business model. That's the whole point. And you say, how do you suffer from so much hubris that you think you can do better? Well, how about not fall into the same trap of cartel medicine? And your patient, and lastly, and your patients are your employees. So I'm not saying they have to come to our services. They could either come to Panhandle Health for concierge medical services, or they can go to their friendly doctor. And let the marketplace and let the state of how they feel about their health make the decision. I'm done.
I appreciate that, Dr. Fletcher. And I think, where it was really going ultimately is that it's an opportunity potentially for the counties to save some money, potentially again on their healthcare costs for their employees. That it is the whole idea behind this is not necessarily to provide the cartel healthcare that you're suggesting, but also to create an environment where it doesn't cost money for an employee to show up. They can do their regular blood work, they can do their regular physicals, and that hopefully by establishing those good habits, you can address issues before they become full blown and save money that way. That is the intent behind it. I don't believe the intent is to continue to provide the same cartel level of medicine, but more to get people engaged in the process of their health so that we can circumvent these issues before they become very expensive. And if that were to work, it would open the door for the counties, which is something we look at all the time, especially because we self-insure, is where do you have your stop losses at? Where do you have your deductibles? Things like that. Because healthier people don't need to worry about their deductibles as much. So that's the intent behind if the clinical services can work this year. Now, a couple other things too that we discussed that you didn't mention today is that the clinical services, if they don't work, and you should know this within the first 6 to 9 months, approximately, maybe up to the full 12, if they don't work, we won't be having this discussion next year on the budget. That if we can't make this work, then we gave it the try and we're done with it. So that's the one thing. And the other, which I think is a question that we probably should address a little bit, is how is the income model determined for clinical services? Because last budget meeting, we discussed for every dollar spent with clinical services, $3 are expected to come back. Can we talk a little bit more about how that's arrived at?
Yes, sir. Empirical data. We can look in our own historical records and see that a given nurse practitioner generates in revenue 3x her salary. And you can also, I can tell you that I practiced medicine for 42 years, and somehow or another, I always managed to make a living. And my company had 1,000 employees. It was a big enterprise. So my services, my cognitive services, generated enough money to pay for a whole bunch of salaries, a whole bunch of buildings. And the reason that occurs is because medicine is 20% of the GDP. It is a big enterprise. So it is not a flight of fantasy to think that you can have a skilled human being, a so-called healthcare provider. Back in the day, we were called doctors, but in any event, a healthcare provider with a cognitive skill set that doesn't have the ability to generate income. And it's in our own coffers, it's roughly 3x. If you're an electrophysiologist, a cardiologist, you can probably do 10x. Depending upon what kind of services you're rendering, there's actually a whole lot of upside potential to make money. Did I answer your question?
I think so. I wanted to ask any of the commissioners on the board if they have comments, questions, want additional information so far what we've discussed.
Commissioner, I have a comment I would like to make, if you don't mind.
Yes, is this Commissioner Corn?
It is. Sorry, there's no way for me to tell you who I am. I guess I'll just have to say it. I would just like to take a moment to thank Director Fletcher on the time spent thinking outside the box, coming up with a different model than everybody else has, not just doing the status quo, not just taking the path of least resistance, not doing what's easy, but for actually caring about the people. There are people that still care about others. That that's why most of our commissioners are doing what they do, is because they care about their constituents. I really appreciate the fact that we're looking at alternative ways of making money, revenue of supporting the clinical services, such as the PMR model that was just discussed. I think there's a great opportunity here for the counties to actually take advantage of these services. It's a great, it sounds like it's a great service when it was presented to us by PMR, but they're making money off of it, and it's going to cost us more money. Whereas if something local like the Panhandle Health District were to provide those same services, are going to save the counties a lot of money. And in the end run, what we're really trying to do is not just about money, but it's about our personnel. It's about the people and the employees getting healthier, being more productive at work, less time off. All that comes into the equation. So I would just like to thank you, Dr. Fletcher, for thinking outside the box and taking the lead on this. I don't know anywhere else in the country that this is actually being discussed right now.
Well, thank you, Commissioner Corn. With accolades like that, the check is definitely in the mail.
Right.
Anyone else have any comments or questions for the commissioners?
Yeah, I have a comment or question about the concierge. You know, we discussed that earlier. How would that work in our area with, you know, I'm not sure how many times a month that our clinic is open, or is it once a week? You know, I haven't been on the board, so I'm not really sure. How would that help our county?
Okay.
How could we?
So this is Commissioner Zimmerman from Shoshone, and we're getting into some operational stuff here, but I think, you know, conceptually, and I'll let Dr. Fletcher confirm this, conceptually, it is to try to establish a day or two, depending on, you know, how the volume works out. But Dr. Fletcher?
Well, thank you. And you're correct. The way I would imagine this, it's a detailed question, Commissioner Zimmerman. It's a legitimate question, particularly as it relates to how do you extend services to rural areas. And this is not specific to Health District 1. This is universal. Telemedicine, I think, is going to have a role to play here. I think the way you approach patients, if you say you establish a relationship with a patient, you're going to have an intake. You'll have at least an hour or so where you will come to know the patient. You'll do a thorough history and physical. You'll have a baseline. You'll know what the basic state of health of the patient or lack thereof. And then moving forward, you would on a periodic basis have clinic days once or twice a week, and then you would see your regular patients on those clinic days. If it's an emergency, well, then you have telemedicine, and if it's a super duper emergency, well, then you go to the emergency room. The idea, most of this reconceptualization of how to deliver healthcare is not so much have a problem, fix it, have a problem, fix it. It is how do you avoid the problems in the first place? And you can accomplish that with the appropriate sort of understanding of the model of how human beings live. It's a model of biology itself. And to be quite honest with you, that model has been perverted for about 100 years now. So it's possible to deliver really decent health care that is more informational and, if you will, philosophical to the people of your county. It's doable. It gives them, it's a matter of reaching into their minds and having them rethink how they approach health. Did I answer your question?
Yep. Appreciate it. Thank you.
Thank you. Any other questions or comments on this topic? Because we're dealing with clinical services right now.
Yeah, this is Mark. Can you hear me? This is Mark from Benoit County.
Yes, we can hear you.
Can you? Okay, thank you. This is a huge topic, and it seems like, and I know I'm probably coming in, it was presented to us down in Benoit County, and the word that keeps coming up is conceptual. Well, it just seems like this is bigger than a conception. If it doesn't work, you're out quite a bit of reserve funds, and it just seems like, and I'm not going to say it wasn't well thought through because it sounds amazing, but the concern is it seems like if you was to do a pilot study or within one particular area, and then, because I know Benoit County, I heard we're 2 days a month, and I don't see that. It might benefit a few people 2 days a month, but it's not going to make or break whether it's here or not. So it seems like you would apply it to one area and see how it works, and then maybe expand the following year or something, instead of putting all your eggs in one basket. Well, it just seems like that you're asking for a lot. There was just like the clinical services, we have a struggling hospital. There's so many things that are happening in Benoit County that this would hurt, as far as taking patients away from the hospital, their clinic. So I guess it's a pretty, I don't know. I don't want to be a negative because it's a positive thing. It's just that it's a big pill to swallow in such a short time.
Could I just address that real quick? The initial conversation, certainly at the last meeting, was talking about whether or not to continue clinical services, and if we were to continue it, to try to do it the right way, and that the money that would be used to do this operation the correct way was to take the money that was never spent but authorized in previous years and use that money to go out and hire the people necessary and provide the clinical services that Panhandle Health has been providing for a long time, not to dig into rainy day funds. So I think that needs to be differentiated, because it's not really digging into savings as much as it's using the money that it never spent, which was authorized to be spent in previous years, and saying, look, we're either going to do this the right way or we're going to stop it. Now, if we do this the right way and we can get this going, then the next step B, would be to look at providing these clinical services for county employees. Counties are the ones that contribute this money, and so therefore the counties are the ones to get the benefit by supporting such a program. So it's really, I want to make sure that we're not talking about step B as the decision, but more so step A first. And if that works, then we can talk about step B and how that would affect each of the counties. So I just want to make that differentiation before we go too far down into making this a discussion about concierge services for county employees. Commissioner Bertling, you had something you wanted to say.
I would be right on board with Mark in his comments. We are in the same position with our hospital. I think that I think this, everything that Dr. Fletcher talked about should have been talked about 2 months ago, 3 months ago, and that would it. So then we could have discussion amongst our our commission board about it. And that's this is the first time I've heard really of the concierge concept and everything. And so I'm not one to jump at things fast like that. I think that if it can work, it would be very beneficial. But I do have my doubts, and I'll leave it at that.
I think it's important to address the hospital issue because I think that is an important component. And I just want to kind of lay out some context here, and then I can be either corrected or what I say will be affirmed. But one of the challenges for hospitals is when people show up, especially if they don't have health insurance, and show up to the emergency room because they weren't getting care beforehand. And that actually hurts the hospitals. So I think that there might be some opportunities where the pain points can be discovered for the hospitals, and Panhandle Health can work to address the pain points and not create a deficit for the hospitals. Is that something, Dr. Fletcher, would you tend to agree with what I said, or am I should stick with dollars and budgets and spreadsheets?
I wholeheartedly agree with you. There's no reason at all we can't collaborate with the local county hospitals. As a matter of fact, I'm going to a town hall in downtown Sandpoint at 5:30 this afternoon to discuss. There's a discussion on expanding women's health services in Bonner County in collaboration with the county hospital. And at our presentation, I say our Panhandle Health presentation to our commissioners now probably 4 months ago, the conversation has been ongoing, that we were going to expand women's health services because that was the feedback we got from Dr. Pennock's audit. So actually, I think there's a world of opportunity here to collaborate positively with the local medical community, including the hospitals. That's how I see it.
I would disagree with that. I don't think that it would be on the scale that would really, at this point in time, benefit our hospital. We are in constant talk every 2 weeks now with our hospital board, trying to get them on the right track and to address the emergency room issue, trying to dial that into who's using it. And I think two days a month at this point in time, I can't see it. But and I think that conversation really needed to be had prior to this with our hospital from PhD probably. That would have been beneficial for this meeting.
Yeah. So I just want to understand. I mean, I understand your concern a little bit, but what we're really, the decision here is whether or not to even try to do the clinical services the right way. And, so if I'm hearing you correctly, Commissioner Bertling, is that the clinical services is a threat to the hospital.
Yeah.
And so by virtue of having it, that creates or poses a threat to your local hospital.
It's the revenue stream, and it's the fact that they do have clinicals across the street, and finding and PhD has to get those patients there and solicit. That's a huge thing. So
Would that be the same, Commissioner Reynolds, for you?
Yeah, I think we're very similar in the county hospital, but there's more to it. This almost sounds like, Panhandle Health has been great for Benoit County. And they've been frugal with their money, and it's been an ongoing, it's been a good process. Years ago, they had nurses on that took care of a lot. We had one state, actually a couple of them here at one time, not doctors, nurses, and they were able to do a ton of stuff. So I almost just feel like Panhandle Health is not staying in their lane. I don't think we're a clinic. I don't think we're a hospital. I don't think we're we should be hiring doctors and doing all, I mean, it just seems like we're jumping out of our lane. But again, it's a concept right now, so it's hard for me to wrap my hands around it because it is a concept. It's really no business plan. There's been talk and stuff that, yeah, hopefully it'll work. But I just, it's hard for me to represent Benoit County and you know, and get on board with something like this, even though it's not a big expense to Benoit County, but it is an expense to the overall Panhandle health.
Well,
So,
okay, so I want to make sure that I'm clear on this because I think that would be option 3. We haven't discussed COLA yet, but option 3 is budget without the clinic with the COLA, and the delta for each of the respective counties. Benoit would be $2,466. Bonner would be $16,578. Boundary is $3,501. Kootenai is $52,105, and Shoshone is $3,463. Is that correct? That those are the deltas for the counties as far as dollars contributed if we were to eliminate the clinical services?
Yes, sir.
May I jump in here real quick, Commissioner
Yes.
Corn? So many months ago, I took the liberty to talk to the CFO of one of our large medical clinics up here in Bonner County, and was talking to him about what's being discussed right now as far as Panhandle Health taking customers away and costing them money, costing our local hospital money. We have a county hospital here as well in Bonner County. And it was at face value. I believe the same thing that the other two commissioners are discussing right now. So I had this conversation, and it was quite interesting that it actually was quite the opposite. By not providing health care to people when it's needed, and those people don't seek health care until it's too late, actually ends up costing the county more money when they end up in the emergency room and they can't pay. That's when the county ends up having to flip the bill and all that. So that changed my mind because I did believe the same as the other two commissioners did months ago, and now my mind has been changed after having that conversation that the emergency room is the last place you want patients showing up at, because that's when there is a problem, instead of trying to prevent it when it's easily preventable before you get to that point of extreme measures and having to show up at the emergency room at 3 o'clock in the morning or whatever, having to be transported down to Kootenai because of something that the patient waited too long on. So that being said, I totally support Panhandle Health doing what they're doing, and especially with their new model, like I said earlier, about preventative health care. Let's keep the patients and our residents out of the emergency room where it's actually costing our taxpayers more money, and get them into some health care, some preventative health care. And I think the numbers that were just read to us, Bonner County was like 16 and change or something. I think we're talking about roughly 70,000 and change across the board being distributed across the 5 counties. Some of the counties only having to come up with $2,000 or whatever for a model that is actually going to make our citizens healthier, and to actually keep the county costs down, supporting our hospitals of people that wait till the last minute to get care and can't pay. That money has to come from somewhere. So let's prevent them from going in there in the first place. Thank you.
Okay, thank you. Any other thoughts on this? Commissioner Zimmerman, you between your county, Shoshone, and Boundary, you're looking at about looks like roughly $38 difference in contribution, a little bit less. I think what this really comes down to is, one, the issue I'm hearing is do no harm to the existing hospitals, but also there is an opportunity for a few dollars to try to build this out in a way that it should address, one, to make sure it can work, but two, that it can address the needs within the counties, which does not appear to have happened, at least in a suitable way, for Boundary and Benawat for their respective local hospitals. So what are your thoughts on this?
Well, my thoughts on this is this is temporary. It's not temporary, but I look at it as giving it a chance to see where it goes. This is where we're at right now, and if it does succeed, we always have next year. That's kind of what I'm looking at, and I'm interested in the concierge to see how that works out, because I think that would benefit our local or our county. So I'm just, I'm really looking at, going through with it.
Okay. We haven't talked about the COLA. Do we have thoughts about that? Commissioner Burling.
I'm fine with COLA.
Okay. Commissioner Reynolds.
Yeah, I'm fine with that also.
Commissioner Zimmerman
Yeah, I'm fine as well.
and Commissioner Korn.
I'm fine with it as well. It's just too bad that the sequence of events takes place, that this comes before our county budgets, as far as our own employees, and we don't know if we're going to be able to do COLAs or not. After some discussion on this, without doing a deeper dive into looking at, I don't know if Panhandle Health has asked for COLAs consistently year after year in the past 5 years, or if they haven't. I don't have that information in front of me, but I'm fine with moving forward and approving that.
Okay. Well, it definitely is one of the challenges with the fact that some taxing or some jurisdictions have to have their budgets finalized before us at the counties have to have them finalized, because otherwise we can't finalize our budget, especially when it comes to any kind of payments. So I hear you on that. And I do agree that we have to be careful, because if we start looking at is one jurisdiction doing something that we may or may not be able to do, then we have to have a historical context. And then if it starts with COLAs, will it expand into technology and basic equipment and consumables and things like that? But I think your point is very valid. So with that said, it sounds like the only issue right now is with the clinical services. Everyone's spoken on that. So the next item is the budget proposal itself. And with that said, we have a budget before us, and we're going to start with the baseline, which is to include the COLA, which the commissioners agreed to, and start with the clinical services on that. So do I have a motion to approve the budget as presented with the COLA and with the clinical services?
I will make the motion, Commissioner Korn, to adopt the budget, including the 2% COLA and the clinical services.
Do I have a second?
I'll second it.
Discussion?
Yeah, this is Mark with Benoit. I know when we all do budget, it always comes down to the whether you can afford it or not, and bottom line. And looking at what everybody presented, it's not that much difference to have the clinic. Where what makes it difference is the unknowns down the road. So as far as you affecting Benoit County Hospital, I have no idea. Nobody does. But that's was my concern. But if you're looking at the overall budget and what your budget that you presented, I think it's a solid budget with the clinic, and that's where you're at right now. But I just, so it's not, I don't want to say it, it's hard to put a value on concepts. So I guess that's where I'm at. I think it's a great deal. I think what you're trying to do is, if it works, it's going to be great. It's going to affect Coeur d'Alene area, the bigger areas, a lot more than the rural areas. So maybe I shouldn't even be worrying about the rural areas, because we're not going to be really one way or the other. We're not going to benefit from it. Or if you're not here to see patients but once a month or whatever, then that's a small number to worry about.
Yeah. Any other?
So anyway, sorry.
No, I cut you off. Sorry about that, Commissioner Reynolds. Did you have
No,
more you wanted to
no.
add?
No, I just wanted to make sure that I mean, I don't want to be the person that is bad mouth Panhandle or anything, because it's not about Panhandle Health. They have done great services, and Benoit County needs them. So this is an issue of, anyway, about the clinic, not necessarily about Panhandle Health.
Understood. Any other comments or discussion?
One of the reasons why I'm pushing forward with this, because it is a concept, but also, we have a year to see how it's going to work. And in that year, to see if it pans out. And then we also have a year to see if it affects our hospitals. And then, we can always step back at that time if that happens. So, I'm looking at it as giving it a try and see where it goes.
Thank you. Any other comments?
Yeah,
This is Commissioner Corn.
Real quick, Commissioner Corn, can you get just 1 second? Commissioner Bertling was just starting.
Sure.
I really wish that people talk about in society nowadays about transparency, and when a lot of this information now has just come out today and we're supposed to make a decision, I have the trouble with the transparency part of it. I think this would have been brought forward to our board prior, that we could have definitely probably gone on board with this, possibly. And I think the concept is great. I have a problem with just how this was handled.
Commissioner Corn?
Yes, I'd just like to just say, Panhandle Health has been providing these clinical services for decades. And something that we're facing today ever since COVID is the mistrust and the lack of trust that people have with the medical professions these days. I see what is being presented to us today from Panhandle Health as a huge step forward in regaining the public's trust in our medical services right here in North Idaho. What better place to start doing that? I haven't heard it talked about today in this meeting. Last week at the business meeting, the board went ahead and voted in informed consent. And personally, I think that's a huge thing to have with today's mistrust of government in general and mistrust of our medical professions, that we're not being told all of the truth of what is actually good for us, what's bad for us. I cannot make an informed decision based on the information that's given to me from my doctor, because a lot of times the doctor may not even know all of the downsides or the side effects. And I'm really proud of the Panhandle Health District Board last week, finally, after about a year of working on this, being able to approve this and move forward. I would love to see them have the opportunity in their clinical services this upcoming year to implement that and to show the people, as was spoken earlier, from our rural areas. Bonner County is mostly rural. We have tons of people living out in our rural communities that want to be self-sustainable. They care about their families. They want medical freedom that we just don't have. And here it's being offered to us for a couple $1,000s a year. How we could turn that down, I don't know. I would like to see them given the chance to show us, show the county, show the people what they can do, what they can implement in this upcoming year. And then look at the numbers. How did it affect the hospitals? I don't have any data in front of me showing me that the hospitals are being affected currently. So I can't make a decision on that one way or the other. But I would like to look back a year from now and say, wow, this was a great thing. The hospitals weren't affected. Maybe even save the county's money, like I said earlier, keeping people out of the emergency room, hospital or transports down to Kootenai County, which all cost us money. And actually, the people using Panhandle Health Services, clinical services, more than they are now, because it's not just another medical institute. There's actually something that is wanting to help people get healthier. And I can't find that anywhere right now, personally. So I'm in total support of giving this a year to see what Panhandle Health can do with this concept. And I wish them all the luck, and I will support them however I can in the upcoming year.
Thank you. I just have a question for staff.
I'm sorry to interrupt you. This is Mark. I just want to, can I say one more thing on the gentleman that just spoke? He made some very good points, and I just want to make sure that before we get to the voting side of things, that if I heard earlier, Panhandle Health is committed to visiting with the hospitals and to work together jointly. And I believe that's what I heard. And is that a commitment that Panhandle Health is saying they will do?
Dr. Fletcher, could I ask you that question or?
Yes, sir. Well, I can make a commitment that we will reach out to your hospital leadership and integrate as best we can our services with their services so that we make for a healthier community. Now, the reciprocity, I'm hearing from Commissioner Bertland that the hospitals actually don't want us to be around, and that may be true. What I can, you can't make someone love you. What we can do is reach out a hand of cooperation with the county hospitals. That I can pledge unequivocally. We will reach out to your local county hospital. Yes, sir. Where that goes after that, I don't know. It's out of my hands.
I have a question for staff. Have any of the counties notified Panhandle Health that any clinical services has adversely affected these hospitals? So at this point, this is largely the first time that Panhandle Health is hearing about how small local hospitals are being affected or may be affected by clinical services that have been ongoing for years and years and years. Is that what I'm hearing?
Well, this is Mark again. But what you're saying is the old model where we had nurses. I don't know that all counties that have. You're saying we've had this clinical services for ongoing at this model before? Is that?
We've been paying for this for years and years and years, which is why, because some staff have not been hired, this is where the money is coming from, because the staff has not been hired in previous years. But we have been funding clinical services for years and years and years.
Yeah, thank you.
Okay, well, with that said, we have a motion, we have a second. It's a roll call vote. All those in favor, we'll start off with Commissioner Bertling. Nay. And Commissioner Reynolds.
Nay.
Commissioner Zimmerman.
Aye.
And Commissioner Corn.
Yes.
Okay, right now we have a tie. Given everything that I've listened to and my discussions with staff, I think the upside of what can be done with Panhandle is so big that it's certainly worthy of trying this service to do it the right way for one more year. We have been funding it for the last as long as however many years. It's not a brand new service. It's an opportunity to do the service the right way. And because of that, and because of the fact that I don't believe that we have a problem with transparency as much as we may have a problem on just communicating our ideas a little better, and the fact that Panhandle Health has not been getting feedback from other counties saying that these services have affected their hospitals. And so if we're going to use the argument of what could happen by doing clinical services the right way, we should just as well have discussions on what isn't happening with clinical services. And so I don't believe that we can use that argument. And because of that, and I duly hear and note those counties that have said nay, but because of that, the burden will be on Panhandle Health to provide a great clinical services this year. And if they can't do it, I hope we don't ever have to deal with it again. So with that, I'm going to vote aye and that the budget passes. And with that, we did this within an hour. It's 11:57, meeting adjourned, and thank you all.
Thank
Thank
you.
you.
Sir, very well done.
Thank you.
I hope we don't disappoint.
I have all the confidence in the world in you guys. Now the ball's in your court.